and
Okay.
get here.
Okay.
Okay, so I think one of the ways to start this session could be to know for each family which is their main problem, for example. That could help us to start prioritizing things. So you can
GI problems.
GI problems.
We have a you know.
Do we want to pass around the mic or is it?
Yes,
okay?
yes.
sorry.
Sure. I can come
Pass around the mic, and also please introduce yourselves and tell us your child's diagnosis.
The name of your child.
Of course.
Sure.
My teacher voice is asking, might it be better if we sit in a circle?
Sure, let's do that. Let's do that. Can we pass around a stress ball while we're at it? Hold a blankie.
Watch your coffee.
Sorry, let me move that guy. I was gonna say, if we could sit Indian style on the floor, that'd be. Oh wait, you can't call it that anymore. Come on. Sorry, that was so Gen X of me. Wow, Grandma Gen X. Why don't you call it Indian sitting?
See, I'm the new generation they came up with.
Why?
Exennial. I'm in between millennials.
Oh, so you're younger.
Yeah.
Gotcha.
Between X
They
and
decided to come
millennial.
up with a new one.
Exennial.
We're full on. Yeah.
Old.
Old. Our parents aren't baby boomers. Sorry for people who are going to listen to this and wonder what the heck we're talking about. We have a 10-year-old named Alec, and our biggest issue right now, and has been for the last 3 years, are GI issues. So he,
7 years.
well, yeah, on and off. We had some pulmonary issues to begin with that were a priority for a while. But with the GI issues, he has, you know, I mean, he has a little bit of trouble chewing and eating, and we always call it eating for sport. You know, it's really just for fun. So he gets all of his caloric intake through his J tube, and he gets 1,200 milliliters of formula.
Roughly, yeah.
Roughly. And we have him on the ProBio formula. We also give him Culturelle, the little packets, which may or may not actually work. And he is on 35 milligrams of Miralax twice a day. And we inject that into his G-tube. We give him all his meds to his G-tube because we heard that Miralax works better if it goes through the stomach. So we make a formula of Miralax and put it in, and he also takes cyproheptadine. How much of cyproheptadine?
7 milliliters.
7 milliliters of cyproheptadine, which is supposed to help numb the stomach.
I'm not even sure anymore.
Yeah, it does something like that. That's supposed to, yeah. And then he also takes a number of nose stuff. We rinse his nose, saline, once a day, which he loves, as you can imagine. We don't use a neti pot. We use a little squirter thing to clear out. And we have a sucking machine, sucker thing that we use to mucus out, because, you know, especially like here, we all kind of have that runny nose. And it's our impression that what happens is he gets a mucus buildup of some kind, or even just the motility in his system slows down. Because the RGI doctor describes motility as a wave or as a cycle, that you have a motility cycle that occurs. And so sometimes it's slower, and as you can imagine, low muscles meaning the GI tract is very slow. So that's what we run into. So we give him all these medications to try to help him push things through, to try to help stimulate his bowels. And and he's still for a period of time, he was throwing up at least a 3 to 4 day cycle 2 times a month. So, and he just gets sick, and this yellow goo comes out of him. And we drain him through his G-tube. G-tube, we drain that, we let that fluid drain out. And we also, we try to move him around, sit him up. We give him Qposa during these stents of throwing up, because the Qposa is supposed to help dry up his mucus. But you can't use it for very long, like other nasal things. It doesn't work if you use it, long period of time. And we still deal with these GI issues. I mean, literally, there was a period of time we were giving him, what was that antibiotic we were giving him? Remember the erythromycin? Yeah, we were giving him like food, and then we'd stop the food and give him water, erythromycin, water, and it was, Mike is his full-time caregiver, and it was a full-time job, for a period of time. Yes, yeah, he's on the spectrum. He's at about 50% of his age category. Yes. Good nutrients, exactly. Yeah, I mean, he's very vibrant, and he's got a BiPAP that helped tremendously with the CO2 and the headaches and stuff, and we went through that. We got the 2 tubes because we were trying to deal with the fact that his stomach wasn't, strong and accepting, and that's why we put the food in the jejunum. And what else? I'm going to hand the mic over to Mike.
From 2 to 3, he didn't gain a pound. He was eating through his mouth, and he was eating quite a bit when he was 1 to 2, and then it just slowed down, and he didn't gain an ounce. So then we decided to put him on the feeding system, and trying to balance getting enough calories in him and moisture would easily overwhelm his system. And then for some reason he's very mucousy. We've had his stomach scoped, and the doctor's like, I've never seen anything like it. It's just like a spider web of mucus. All that combines, he gets backed up for 2-3 days and doesn't have a bowel movement, and so then we got to flood him with Miralax. But in the meantime, until we could get that dialed in, he was throwing up probably 25-30 times a day for anywhere from 3 to 10 day periods, and he'd be good for a couple months, and then he would drift. But while we're trying to dial in keeping it perfect, we may go too far on the dry side, and he'd be backed up. So
it is such a remarkably, just to
Fine
get
line.
it down to that. And so we're just asking, our question is, does anybody else run into these things? Have you found any other treatments, any other procedures, or can we help, obviously, anybody else?
Okay, anybody else?
Oh, sorry, you want to give your...
We've been having GI issues. I have a 3.5-year-old named Levi. He had a G-tube put in when he was 2 because he was starting to lose weight. He's 29 pounds. The G-tube, he was randomly throwing up, wasn't getting the nutrients he needed, so we switched to a GJ. With the J, for whatever reason, he would throw up at the same time every morning. Not sure why, but with his BiPAP and the risk of aspiration, we stopped feeding through the J and started again through the G. And we just haven't found the right balance. We've tried erythromycin, we've tried Prevacid, or we tried Miralax for a while. We used the Culturelle stuff. We've tried a number of different formulas. We're kind of just, I don't know. He's had the BiPAP since he was just before he turned 2, I think. So a while. Okay.
A lot because he was
every morning.
Yeah, he was
Yeah.
sick every morning because of the CO2 intake, I would assume, or the lack of being able to,
Yep.
to push it off.
Yep. So we're not really sure what to do. It's been since March 6th. It's been every day. We just can't get it under control. So
I don't mean to be rude, but what color is the stuff coming out of him?
it depends. If he was being fed through the J, it was just like mucus that would come up. If he's being fed through the G, then it's whatever he's eating.
Gotcha. Anybody else?
Does any of your children have reflux?
No.
No. No. In fact, Alec had never thrown up before he started his feeding tube. We thought, oh my gosh, this kid's never thrown up. Like every kid throws up, So there was like zero reflux.
No. Ours does not. We had an endoscopy done, and they didn't find anything wrong in there. And we've been through a myriad of tests and procedures and everything, and there hasn't been any indication to do something like that. And similar to you guys, Levi never threw up before having the G, but he doesn't want to eat. I mean, we were taking hours and hours and hours trying to get him to eat a meal. So.
Okay, so the other children have no main GI problems? It's okay?
We do.
Sorry, I don't know why
Mine-
I just left my purse in the middle of the room.
Christian is 18 months. It's definitely not as much going on, but he's only 18 months, but he's been having really, really bad constipation and like impacted stool. And ironically, this weekend he's not eating, and he's an awesome, awesome eater. So I think Levi and Christian are very, very, very similar in terms of the spectrum. So.
I just wanted to say that, so our son Charlie is going to be 9 in September. And when he was I would say around 18 months to 3 years old, he did not want to eat very much at all. So we did have some issues. He was always below the weight chart. He was always just below, like 10% below. And so, several doctors had talked to us about a feeding tube. But it was around that time when he was about 3 that we met Dr. Collins, and he put him on the prednisolone. And as soon as he started that, he started eating more, and we haven't had a problem since. So I don't know if that was the reason why, or if that was just a coincidence, but that did help a little bit with him, being able to gain weight and maintain weight. No.
So many of my children with LMNA, the growth chart is very specific for each child. I keep my less experienced GI specialist had a tendency to freak out when the child was that far below normal weight. Yeah. And then I finally found a GI specialist who knew neuromuscular disease, and they understood that the child's growth curve is individualized and that you have to monitor the growth curve for that child over time, and as long as they don't fall down below their own growth curve, you're okay. And yes, you're going to be much lower weight compared to a regular child of that age, but it's their own growth curve that we need to monitor. And in terms of my children also have a tendency to vomit a lot as well, and it almost always correlates with poor bowel movements. And so besides the careful regulation of fluids and bowel Miralax, and the other big component is movement. Yeah. So a lot of my kids love pool therapy. In San Diego, we have an affiliation. We have this, we have a free clinic, free at YMCA admission. And I would highly encourage, if at all possible, for your local hospitals to get a affiliation with the local YMCA, and it's actually taxpayer supported. So all the kids go to pool therapy, and it's supervised by the YMCA staff. There's an agreement, and the kids love the pool therapy. And activity, we know that in neurology, activity correlates with bowel movement. In fact, like adult patients who have a stroke, they're in the hospital, they don't move for a while after the stroke. When PT first gets them out of the bed, the first thing that happens is that the person poops on the PT's feet. Okay, there's a good correlation with movement. So I do recommend regular activity to keep the bowel movements going. It's a very natural way of getting the bowel movements going. Yes.
His tubes can't get wet.
So there are different types of tubes. My kids have buttons put on that you can protect, and they can get in the water. Again,
How do we do that?
You have to talk to your GI specialist. It has to do with the GI specialist. There are certain specialists who will promote the movement, and they understand the neuromuscular kids. You just need to find that right person, not you, but maybe your clinic needs to find that right person who's willing to work with the neuromuscular specialist, going, okay, this button allows you to go in the water, whereas this other tube is not safe to go in the water. Yeah, so yes, there is a specific tube that is actually safe to go in the water with. Yeah, so I found that to be the best way, but otherwise, my parents do struggle quite a bit with, constipation versus diarrhea, and the diarrhea is usually because of too many laxatives, and then you have to and then a formulation change, especially if a formulary just stopped carrying a certain brand that my parents really liked. That's also another problem, because it changes the chemical nature of your diet. Right? So things like that can really help. Like I try to do as many natural things as possible. Movement, yes. And that's actually very therapeutic. The kids love being in the pool. So, and it's a warmed pool. Yeah, it's a warmed pool. So they are interacting with other children most of the time as well.
If you guys live in a major metropolitan area, we've used the Easter Seals pool. They have a 92-degree pool in Colorado that we use. You could use those facilities too, I think.
Yeah.
The therapy pool.
Yeah.
I feel really fortunate that, I don't know about these things yet. We're still, but
We're just 10 years old.
yeah. Liam's almost 9.
Oh,
Yeah, so a little bit. But really, we're starting, and you guys might be the best to go with this because, like, Christian's not going to be dealing with this. He's a baby. But Liam's starting to, he's going into 3rd grade, and I'm just thinking about some of the, like, social issues and emotional issues that go along with this and kind of self-identification and maybe some of the things that you guys see in clinic. Like, we're honest with him about the disease, as honest as we need to be in that moment. We certainly don't talk about lifespan or, maybe some of the things down the line that we don't really know about. But how do you guys talk to your children about the disease? What are some of the words and phrases that you use when they're feeling like, what is going on here?
That's a good question. Do you have any insight on that?
We've been straightforward with him right from the get-go. I don't know if I have any specific pattern phrases that I go to. We just talk about it as it comes up, and
We just pretty much told him from day one that he has that he had when he was born, he had a misfiring of, one of his genes, and his muscles just don't work the way other kids do. And, right now there's no cure for it. And, and the hardest part really is, and this is super simple, is playground. That's where we find the most difficulty because the kids want to go play, right? So he has a para, and we're in a school of like, what?
his class is about 45.
45 kids, yeah. We live in a little...
Two classrooms, sorry, that age group.
Yeah, sorry. So, it's pretty small, not a gigantic, big school. And he wanted to play soccer. So they fashioned a little guard on the front of his, wheelchair so he could play soccer with the kids. Changed his life. So I would say that, and also, he has a non-affected brother who is 4 years older than he is. And we've just always integrated. Like, there was never a question. There was never a, and he'll stay inside sometimes. And the other cool thing at school is that they do is it's a privilege to get to stay in at recess and play with Alec. It's something that the other kids can work towards, so that makes it special. And then they, the kids want to do it, right? So there is a little bit of like, early accommodation for him that works really well.
Passing it back around.
How about Charlie? What are you guys finding? How do you...
Liam and Charlie are like 2 days different.
Yeah, we actually haven't really talked to him that much about it other than answering minor questions that he has. He doesn't really bring it up. He doesn't get down on himself or his condition at all. So we really haven't had that talk with him. He doesn't show his emotions a lot. So, we don't know what he's thinking that much, which kind of worries us sometimes. But he doesn't ever get angry or frustrated or unhappy like we would think he would. He's just, he's always kind of just adapts to his environment and, just makes good out of every situation, I guess. So we haven't really had to deal with that.
We've done similar stuff that you had said about in school. With recess was a little bit of an issue, but we just talked to the folks and they were kind of modified to him. So when they do a unit that he can't do, they kind of make him a coach. One thing that they did with a very good school district, it's forward thinking and progressive. So they were realizing he was having problems at recess. So one of the aides hooked up with an organization's therapy dog. So 2 days a week they bring the therapy dog, and it's like you guys had said, it's something you can work towards to be with Charlie and the therapy dog that day. But like Steph said, Char's very, he's not very emotional. He just wants to be typical. So and I don't know if it's better or worse. It's probably worse. We don't talk about it much. We definitely don't talk about prognosis or lifespan. We just don't talk about it. And we're always concerned about when he's gonna find that out. Frankly, it was one of the reasons why we didn't bring him this time. We haven't brought him, is we just, it's like...
We feel like he's maybe close to that age, where he's going to start Googling his condition and finding out more than we want him to know. So now
we're like, status quo is all right.
Tell him before he finds out, from the internet.
And I'm like there's no right or wrong. We're in all likelihood we're probably wrong, and it's just more easier not to deal with those conversations now. But we haven't done that. We're just kind of perking along with the status quo and not, upsetting the apple cart. So.
We had an incident. The reason I kind of asked about it is we had an incident where Liam does go to MDA camp.
Yeah, so does our kid.
And most of the kids in his cabin have Duchenne. And recently, Cincinnati has a marathon called the Flying Pig Marathon, and it's a big thing. We happen to be watching hockey on the TV and switched over to the local news. We never watch the local news because it's terrible. But it switched on the local news and they were talking about the flying pig, and so Liam's in the room and they show Diego, his 10-year-old buddy from camp. And Diego's being pushed in a stroller by his dad, who was doing it to raise money, and, he ran the marathon. And the news broadcaster is saying, here's Diego, and, he's going to be permanently in a wheelchair in the next, 2 years and has a life expectancy of 25. Liam whipped his head around and looked at me and went, what? And I was like, I want to tell him, this is a reality of the disease, is that you're going to lose friends, but how do we talk about that without telling him? I don't want him to think, well, I'm going to die at 25, or, we're really at that stage where we're really focused on, because his world is opening up. He's at that age. So, yeah.
As a specialist who gets asked a lot of questions about lifespan, I have learned that it's not smart to guess. It's not wise. You don't want to put a limitation on your child or even your adult patient, because you don't want to set a mental barrier. Like, after this mark, I'm not going to be here. So, and truthfully, none of us doctors can guess. Agree, Dr. Heller?
Yes.
Yes, and I think it's not wise to do that. And so we don't know. So I actually tell, if my child, and some of my smaller children have actually asked me, Dr. Connersman, am I going to die from this? And I tell them the truth. I said, so-and-so, I don't know, honey, but I am going to take care of you. Your parents are going to take care of you. We're doing what we can. And I actually show them the research. I have little PowerPoint slides and I tell them in their own words what it is, what we can do, how we're doing this, and what the next steps are. So I've gotten to the point where I've learned that it's actually not smart to say your child has a lifespan of this to the parents, and I never say it in front of the children. And it's just, you're not going to be correct, and it's fruitless. And no one knows. Yeah, it's counterproductive, actually. So I like to take it one step at a time, and I tell them, okay, the most important thing we need to do right now is make sure we are taking care of your lungs and your heart. And we do that, and they're focused on that. And I tend to talk more about, what do you want to do when you grow up? I have a teenage LMNA patient who was diagnosed later in his life, who's going to be an engineer. He's going to go to UC San Diego for engineering. I said, you go for it. You do what you want. You get your engineering degree. You become the electrical engineer that you wanted to be. So, he asked about having a family. I said, yes, have a family. Fall in love. We'll deal. Yeah, exactly. We'll do what's necessary when it's time for you to have a baby. We'll properly counsel you again and your loved one, and we'll take it from there. So I have a tendency to talk about the future in optimistic views, but they understand that they need to see the heart doctor. Because one time I had told the parents, the child was in the room, that I would like, I believe it was an LMNA patient, it might have been a Duchenne patient, but that your child needs to go see the heart doctor for this reason. I didn't say it in those exact words. And then the child, after I left the room, apparently cried because he thought he was dying, and that's why he was asked to see the heart doctor. So I from that point on, I tell my child why he or she is being asked to see the cardiac specialist. It's only because we're just monitoring you. We just want to make sure your heart's beating well and that is pumping well, things like that. I actually explain everything to the child. But I would like to know, as the parents in the room, what is it that you want your doctor to tell your patient? Based on the age that they're in now. I would like to know what you think, if you don't mind. So I've actually had some parents who don't want me to talk about the condition at all to their child, and they might be a 10-year-old. Somebody, and that child is usually astute enough to figure out that I'm very different from my other friends.
There's power, right? I mean, ignorance is bliss. Yeah, ignorance is bliss. Ignorance is bliss. You're right about that. But knowledge is power. I mean, I loved when, and you seem beautiful about the way that, like, I can tell that how you speak to the children. But, you know, we had Dr. Collins, James Collins was Liam's neurologist, and he was so beautiful. He was just honest and kind, and, you know, and these kids are smart. I mean, they're smart cookies. We're noticing that. They're real bright.
Very, very, very smart. Yeah.
I want to speak to that a little bit because I tend to see the kids when they, more often as they start to develop more heart problems. And I think what you say from the beginning, you say cardiac monitoring is part of routine care for this condition, so they don't feel like it's abnormal to go see the heart specialist. It's just like going to the pediatrician for your routine checkups and whatnot. But by the time kids are 12 or 13, they know something's up. They're aware. They have been on the internet that you are not aware of. They and if they haven't been, it's the big elephant in the room. And my experience is that the kids tend not to bring it up. They tend to avoid talking about it because they don't want to upset their parents. So they say, you know, I think it's it may be wrong to assume if they're not talking about it that they don't want to talk about it. I think that they may be not so much in the younger kids in the elementary age range, but once they reach that sort of pre-adolescent, adolescent age, that is a huge thing, and it's helpful to bring it out in the open. And what I was going to recommend is many pediatric institutions have a specialized pediatric palliative care team. And palliative care is different from hospice. I don't know if anybody knows what the distinctions are. Hospice is one small fraction of what palliative care people do, and hospice is really designed for when you're at end of life. But palliative care is a specialty that takes the big view. They step back and they look at a holistic, whole life process, and they help you not figure out how you want to die, but how you want to live. And what are your priorities? What's important to you? What's meaningful to you? And then help you make decisions when you approach later stages of the disease, help you make decisions that are in keeping with what you and what your child wish. And so they're expert at initiating those tough conversations and giving you the vocabulary to talk to your child about it. Please.
It goes to show that, you know, that like wanting to protect their parents and wanting to make sure that like mom and dad aren't hurting. But when Liam is feeling like, and I think it's almost hard that he is capable of doing so much because he's kind of in that no man's land where he's like, I can do this, but then I can't. But I can do this, but then I can't. So protecting mom and dad, going back to that, it was, we had chatted a little bit about, oh gosh, no, this is a separate thing. We were walking through the mall. This was the story he didn't want me to tell, but I'm going to tell it anyways. We were, yeah, whatever. He's fine. Yeah. So we're walking through the mall, and he just kind of looks at me and he goes, "Mom, is muscular dystrophy contagious?" And we've talked about this and talking about like your building blocks or your DNA and, you know, going to the basics there. But he said, "Is it contagious?" And I said, "No, honey, it's not contagious. It was something that happened when, you know, mommy and daddy were making the baby, and, you know, there was a little tweak there." And he's like, "Okay." And he said, and I said, "So you can't pass it on to a friend, but if you did have children, what do you think would happen?" And he was like, "Oh, I don't know. What would happen?" And I'm like, "Well, we were told that you have a 50-50 chance of a child having it." And I said, "What do you think about that?" And he goes, "I think I would like for my child to have this so they could live a life like me and know what it feels like." And I was like, that is like, I had to take that moment and go, my assumptions of what his thought about his disability is totally wrong. Like there's this new world that he's not, I mean, there are parts of it he hates, but he's not ashamed of his disability. It just is a part of him.
Yeah, Charlie has said, you know, when we've talked about finding a cure, why would I want to find a cure, Mom? I said, yeah. And I said, well, you know, maybe you would be able to walk or do more things. And, you know, he was like, why would I want to walk? I'm special. I'm in my wheelchair. Yeah. You know, he thinks he's cool and he's special because of the way he's different. Yeah.
No, you should want to. But wait, yeah, okay.
Well, building on one thing that Dr. Heller said, I thought of another thing we had started when you talk about the palliative care at the hospital. Our school, I'm sure every school has a school psychologist. So we got charted very early with them, not to talk about any of this stuff, but just to build a relationship so that when 12, 13 happens, they have that resource. There's a history with that person. So it's worked for us.
Yeah, we have a boys group, that's what they call it, the special boys at school, who, there are, I don't know, 3 or 4 of them. Little Eli is missing the lower half of his leg, and, one of the other kids is in a walker, whatever, they just have their own, and they have boys club, and they sit down with the school psychologist, and it's a special time, and, they get to just chat. And sometimes it gets really intense, and sometimes they just throw spitballs at each other the whole time, So if you're, if you do have a school psychologist and they're not yet doing this, I just recommend say, hey, why don't you get the kids together and have a little convo?
There you go. Thank you for all indulging me about that kind of stuff.
No, it's important stuff.
Yeah, especially. And
Okay.
the palliative care information is so, if you don't have a school support like that, you could easily, start a little play group, because play dates are so hard for our kids, as they get older. Play dates are really important. You could do that through your, do you all visit like a muscle clinic? Do you have a care in your area where all the doctors, you see them all at once? Okay, yeah. That's a great.
Well, that's my question. My question is about that.
It's supposed to work like that.
Yeah, I'm curious to hear what other people's experiences are. Our muscle clinic, really a lot of times when we go, we only meet with a nurse practitioner. Sometimes a PT comes in. We have to meet with.
He always comes in.
Okay. Okay.
Check in.
Yeah, for like quick.
And maybe we go down, maybe we don't.
Where are you guys again?
Boston. And so we have 2 really great hospitals. We're supposed to be at the best in the world. It doesn't feel like that. It feels like nobody knows anything.
We were sold on something that we're not getting. We were sold this is an MDA clinic. It's it's part of the MDA. You're going to come here and you're going to have the associated doctors, but it's sort of like we go and but the cardiologist isn't involved, so that's another appointment. And usually the orthopedist is supposed to be here,
Yes.
but not on the Monday that you're here.
Yes.
So that's another appointment. If we have to go into Boston,
How far
that's
do you
like a
live from-
5-hour
Okay.
trip. We're only 45 minutes out of the city, but the
long.
appointment's
Yeah.
always at
Takes the entire
2:30.
day.
We get out 4:35.
Oh, yeah.
Hour and a half of traffic because everyone's trying to get home.
Oh, yeah, we're 56
And-
miles from the children's hospital.
And and then we get in,
We
and
know
because
that.
no one else is there, we're setting up like 3 or 4 extra appointments.
We have 2 others near us that are supposed to be the best, NYU and Columbia, same experience.
Yeah.
So we have an appointment at Mass General, which also has a neuromuscular clinic, and we're trying to figure out like what do we ask, what do we look for? We don't really have many options. We can't come to Cincinnati, twice a year. We have however many. I'm sure you all the number of medical appointments that we're dealing with is insane, and we have to keep jobs, and I don't know how
The
that's
irony
gonna
is
happen.
we're going into, as we park in the garage at Boston Children's Hospital, there's advertisements on the elevator walls and everything of how they won #1 Children's Hospital U.S. News. And we still get a lot of the cardiologist kind of says, oh, I don't know. The orthopedist, we don't have a high level of confidence in them.
The Children's Hospital in Denver also has a, what was it called? Dr. Fox. It was like they have a, because you're looking for a quarterback, right? And
We love the nurse practitioner.
Right,
that's running the show.
right. And for a period of time when Alec was really in high care needs, we went to the special care clinic. That's what it's called. The Children's Hospital in Denver is a special care clinic. And they gave us Dr. Fox, who was like a quarterback. Like he would take everything, and kind of relay it to the GI clinic and relay it to, you know what I mean? And so if you have a kid with special needs and has high care, you might want to check with your primary care physician or the hospital itself and see if they have a special care clinic, because they know how hard it is for us to negotiate all these appointments. Yeah. And that doctor can serve as your, specialized primary care physician. I don't know about you, but our primary care physician runs to his car when we walk in the building. So, that was really helpful.
Yeah. Thank you for that. I want to speak. I want to speak to that a little bit because I think exactly you all have very different experiences depending on how organized your local neuromuscular clinic is, and you are your own best advocates. And it's when you call to make the appointments now that say, is the cardiologist going to be there that day? Is the orthopedist going to be there that day? And don't take no for an answer. And if they say no, you'll have to come back. Say, well, then I'd like to reschedule my neurology appointment so that we can do this all together. And
we can do that.
and right,
That's what happens.
right.
Well, no,
They will often
the
have.
ortho was supposed to be there.
Yeah. But each clinic typically has a nurse coordinator that can become your best friend, and like a Dr. Fox or somebody that is going to centralize the care. And the other thing I would encourage you all to do is get involved in the family advisory board at your local hospital and give them that feedback, because the hospital may not know. They may pat themselves on the back because they're getting all these awards, and yet the patient experience may be really lousy. And if you can tell them that there's no handicap parking when you come for your appointments, they need to know that. Right. And so as a family, being on the family advisory board, you can give that patient feedback to the hospital, and they love hearing that, because we, as a children's hospital, we want to deliver family-friendly care, and if we're not doing a good job, and you're not telling us, we don't know, and we can't get better. So please be the squeaky wheel. Be nice about it, but you don't want to antagonize the people that are supposed to be caring for you, but you do need to be very proactive, and no one can do that better than you.
So what doctors are available when you go to a neuromuscular?
I was just going to give you the lowdown. Okay, so when we go to Cincinnati Children's, we arrive at 8 a.m. And at 8 a.m., at 8 a.m. on the dot, he is weighed, measured, in the room. 8:05, we see either, it's clinic, so we see everybody one day, meaning cardiology, where we've done an EKG and an echo, maybe a Holter if we need to, same day. Cardiology, pulmonology, physical therapy, dietitian, his neurologist comes in twice usually. Gosh, who am I missing? It's the whole team. It's one day. One day. And they crank it out. If you feel like it's a hard day, do it 2 days.
One day would be fantastic.
We don't have those yet. Yeah. His orthopedist, we do go, he gets his orthotics elsewhere. But that's our choice. Yeah, ours is closer to us. We don't have to drive a little bit further, so. It's less than that. I would say we're out of there by 2:30. We don't wait more than 5 minutes between a doctor. It is a well-oiled machine. It's MDA. Honestly, I don't think it's MDA doing that. It's Cincinnati Children's. I mean, and scheduling. Yes, there is. But scheduling, I would say the first 3 years that we were doing this, it'd be well, when's our next appointment? When do we do clinic again? When is it happening? But now I'm in the habit of before I leave that day, when are we here again? And they schedule it. They just say, what day is good for you in this week? And everybody does it. I'm so sorry, because these are hard days on kids. They're hard. And mom and dad, yeah.
You see GI separate?
We don't see GI yet. Yeah,
so we see GI clinic is a separate clinic that we have to go. Sorry, the GI clinic in Denver is a separate clinic that we have to go to. But same pulmonologist, same. The only thing we don't do is cardiac.
At the same time, talking to each other and us,
Yep.
Wow.
And you see it every 6 months. Every 6 months, yeah.
This is MDA also?
MDA also, yes.
Why is there such a difference?
Sure.
So I run the MDA clinic at both the adult side at UCSD and the children's side at Rady Children's and in San Diego. And 2.5 years ago, I was hired because of the MDA clinic being very disorganized. And it is actually Cincinnati Children's is an amazing center. They are indeed a well-oiled machine. And today, for instance, my clinic has a neurologist, a pulmonologist, a physical therapist, our nurse coordinator, a physical medicine and rehab doctor who does the orthotics. We have 2 social workers. We get the same social worker. The family gets the same social worker every time. But I don't have a cardiologist, and the reason for that is because we're having logistical issues with the echo tech and the EKG tech. And so sometimes if a clinic is having some difficulties, it's because of an actual logistical/financial issue. And hopefully the lead doctor, called the director, should be trying to fix this. So if you actually do have a problem with not the consistent doctor, please tell that to the director. Tell that, like, put it in writing, and that will generate something. Like, it ended up causing me to be hired by the entire institution. It ends up bringing in somebody who can organize stuff. It ends up funneling money. MDA actually gives some support, but it's usually to fill in these financial gaps. But it's considering the cost of some of these people, it's actually very small. So be patient. I'm so sorry that this happens. I wish it never happened in any of the clinics, but tell them what the problems are, because it will, if enough parents complain, it will actually cause something to shift. All right. So, and then if a motivated doctor is there vouching for their patients, it will happen. It just might take a little bit of time because there's money involved. That's the problem with all of these things. There's money involved. And I have an amazing cardiologist. It's actually one cardiologist who sees all my muscular dystrophy patients and myopathy patients, but he's in his own clinic. And my main problem is I don't have a space for him. I need another room to accommodate that doctor. Considering we have like 6 different people that sees enough patients, and Rady Children's cannot give me that room yet, but he's ready to come. So see that there's like a weird thing that's blocking me, something that I wasn't expecting. And this is an actual problem across the board. Dr. Heller, do you agree? Like, the reason that you're in your clinic is probably because you're motivated, but you also have a tech and an echo person who's there, correct?
Yeah, cardiology is the least portable of the specialties because we have equipment needs. And in our particular situation, we used to have an MDA clinic where we all met the first Monday of the month, and everybody, they came and had all their appointments on the same day. But then the hospital, in their wisdom, moved pulmonary offsite, but we were growing and we didn't have enough room. And then neurology moved their offices across the street, and then cardiology. The cardiologist before me who did this stopped seeing patients on Mondays. So then the patients started having disjointed appointments, and then we lost our MDA funding because our director retired and there was nobody else to pick up the slack. So we're now in the rebuilding phase, and it is cyclical. And ideally, we should all be Cincinnati, and so. Well, no, I think what you should do is encourage your directors to call Cincinnati and say, hey, can we come for a site visit and see how you guys do it? Because then we can spread that model around the country.
You guys know you go to Mass General?
No, we go to Children's, but we have an appointment at Mass General coming up just to check it out.
Gotcha. I would get an appointment with the director of the clinic, and figure out who that is and just say, I want to sit down with them for 10 minutes. When can I do it? Don't even give them an option. Just,
And the thing about you putting in writing is that it can actually go to the heads of that hospital.
There you go.
If a parent complains and enough parents complain about the same thing,
Mhm.
it usually does end up on the CEO's desk.
Right to the CEO.
Yeah.
Okay.
Yeah, exactly.
Yeah.
Exactly. It will end up on their desk, and then the money they'll start allocating money.
Yeah.
to that.
Can I just ask, in terms of the dollars and the MDA, I was frustrated because we went to the clinics and the MDA preaches that they have these clinics, and what I'm confused about what the MDA is funding. My insurance company is paying the providers to see me. It's not quite organized, so what?
Let me answer that. This is a good question that a lot of my parents ask. So more than 15 years ago, MDA used to give $120,000 per clinic. And back then, the medical bills of a patient could actually be covered with $120,000. I actually have 300 kids in my clinic. And one of their appointments, the actual dollar value is $10,000 for seeing all of us. So and my MDA grant is only $20,000. The MDA's grant amount has been declining steadily. This last cycle, my grant got cut in half. So now you can see why the actual grant cannot fund any of my kids' care, because So all of my kids have insurance because of the Affordable Care Act. Even my patients who did not have insurance before are able to have Medicaid in California, and they're able to get all their care, including their gene testing. So we're able to give them excellent care, actually. Sometimes my Medicaid patients do better than my private insurance patients. They can get more services. Anyway, so unfortunately, I cannot use the MDA grant just because of the dollar amount to actually pay for kids. However, once in a while, if an insurance company is being a butt and they won't cover something, and my kid really needs it, that's when I tap the grant. So let's say I really want to prove the gene mutation in one child, and I do appeals for their denials for gene testing. I then tap the MDA grant. So I have to reserve it for emergencies. So they give us a little bit of money for basic emergencies, and once in a while, like let's say an echo tech, I need to pay the cards department $10,000 a year to get the echo tech into my clinic. That's what I would use the MDA grant for. Yes, it's there's usually a gap, and so I would. Yeah, it doesn't cover it all. I have to actually pay her, or not her, but the cardiology department, the gap. There's always a negotiation. That's why I said all of this is always financial. There's a department-to-department negotiation.
What they're supposed to pay for, they're not paying. And instead, the MDA money, instead of going to research to cure our kids, is paying for what the insurance company should be paying for, which comes out of my paycheck anyway.
So right. So yes. So the MDA money does help, but it has steadily gone down. And I'm not bagging on MDA at all. I'm grateful for the money that they do give me, because it actually does help fill certain gaps, and it actually keeps my clinic going, and it helps me take care of 300 kids and 350 adults. So I have 2 different MDA grants, and both numbers have gone down on both of them.
Just one last question, I don't want to harp on it. In the case where there's a gap with the heart care, let's say, if there wasn't a clinic and the patients were seen elsewhere, they have some of those tests and those care, what happens then? Like, say there's no clinic and there's a gap.
They just, that department usually, yes.
So why does the muscular dystrophy community have to fund that?
So it's that's a very good question, and that was actually one of my rebuttals on why should I have to pay for a tech for, or a respiratory therapist for that amount when that person would go to that department anyway and pay their lower insurance price. Why do I have to make up the gap? But it's a department. Yeah, this is now a department actually vying against another department, trying to make more money. So that's why the pulmonary department that I work with, we are partners. They will eat a cost, I will eat a cost, but we will all together take care of our patients. And because the doctors can directly talk to each other in that clinic, that's what makes it easy. So
That's the difference.
yeah, like when the department's in, yeah, then they win. Yeah, so I just need to get the bean counters on the cardiology side to get to my get on board on the boat.
Can insurance companies be fought in those cases by like an advocacy person like Chase? That was in our room earlier, to accept the gap, like they accept the gap for everybody else. Why are they prejudiced?
So like for instance, Blue Shield, it's huge, and I am not sure that any one of us can actually fight it. I think it needs to actually be fought at the top, but I don't know about that. Yeah.
Do any of you used CoQ10 supplements?
I bought it. It didn't start yet because I've got a lot of good stuff.
Okay. All right. Well, just recently, our son was. Oh, yes. Hi. Do any of you use CoQ10 supplements? Was the question. I personally do. You use? How are they affecting you? I'll come to you. A little bit more energy, maybe.
Maybe, yeah. There's a.
Please say yes.
I mean, I have a cardiac condition, so it's good for it's sort of the benefit's supposed to be cardiac. I've never had my doctor say, "Oh, that's great." My cardiologist,
Sure.
definite benefit. But I take it in the hopes that the research that says it's good is true.
The neurological system, right, which is involved. Isn't it supposed to help?
No experience in that. So,
It's a supplement. So
Yeah.
yeah. Okay.
research to stand behind it is not really, you can't really say it's fully proven and trusted.
Okay.
You're a cardiologist, correct?
Yes, I am a cardiologist, and my experience with CoQ10, I have patients who take it. I think it doesn't cause any harm. I haven't been impressed that it makes a huge amount of difference. There is some literature out there in some adult forms of cardiomyopathy not related to LMNA disease showing that there may be some benefit, and there's certainly anecdotal benefit. When parents ask about it and want to try it, I have no objection. I can't really wholeheartedly endorse it because there's no data. So I try it.
And
And
as a doctor, you say, I don't have a problem with it.
I don't have a problem with it, no.
There's no
No. Right, as long as it doesn't upset your stomach. But, by all means, the only thing is that it's the expense and the inconvenience of having to give it. So if you want to try it, by all means, I never discourage patients from trying therapies that have potential benefit. Just because there's not a randomized controlled trial doesn't mean it's no good. It just means we don't know if it's good, and you can be your own randomized controlled trial. And the problem is there's no way to evaluate the efficacy of it. So I have a patient who comes back and their ultrasound looks the same as it did 6 months ago when they first started the medicine. I don't know if perhaps if they weren't on the medicine, their findings would have gotten worse. So I can't say that there's no benefit. I just don't know.
I started trying to research anything natural that I thought would help when we first found out. And one of the things that came up was human growth hormone, and I guess creatine can help your body produce more human growth hormone, which could help sustain muscle mass longer. And so I found articles and emailed a neurologist in Canada that said that they always prescribe it for muscular dystrophy patients. So then I asked Bonneman, what should we, and he said, I don't have any proof that it works. He's like, I don't think there's any harm. It's been around a long time. And if you want to, here's what I think the dosage should be. And the guy in Canada gave me another dosage, so I tried something in between. And, Christian's young, but we started having those constipation issues, so I stopped. It turns out it wasn't that, but I was stopping it anyway, just in case. But just another
I remember asking
Another thing.
Dr. Collins about that, and he said,
if I remember correctly, he said you're just going to end up having really expensive pee. Yeah. but again, it was the same thing with the CoQ10. Like, there's no evidence, but yeah.
They used it for muscle building, right, in the 90s.
I was just going to say really basic, because every time you guys say something really basic, it always helps me so much. And I think, vitamin D and zinc are the two things that we give our kiddo because they don't get enough sunlight. And also the zinc just helps overall with immune issues and stuff like that. We've seen differences. And literally the vitamin D, those little tinctures, it's 1 drop. Like, how can this 1 drop make a difference? But we think it has, helped him overall. And the zinc we put it in his food bag. It's like 1.5 milliliters or something. So those have been things we have found that have helped.
That's good.
Prednisone?
Yeah. Because I think the instructions are, you need to make sure they're taking enough vitamin D if they're taking.
Oh, maybe that's why he does it too. Yeah, right.
For bone density.
Right.
Did you guys talk about nebulizers yet?
Yeah, but I'm a big believer in vitamin D because I think kids that are not weight-bearing have a higher incidence of fractures, and vitamin D to help keep and none of us get enough sunlight, as we're all sitting in the dark room. So yes, and especially if you're on prednisone because that weakens the bones. So.
Okay, so
Nebulizer. She just asked about a nebulizer.
Has anyone used it? Has anyone used?
We haven't used one yet. So we haven't used one yet, but I appreciate your question because I now own one and have the things that go with it. And we've been fairly lucky that she hasn't been sick, and so we don't exactly know what's going to happen when she does. So we're also trying to get a cough assist. And
our non-affected daughter had croup when she was a newborn, and we bought, our insurance, we just bought her for $50 or something
For the nebulizer, and it was really helpful. I mean, it was, and so now, and they said anytime that she is kind of having a bad cold, you can give it to her and it's okay.
I don't know if we're a little bit weaker in terms of chest muscles, but he's had to be on it probably almost once every 3 months at this point. So if he gets a cold, it seems very hard for him to clear. So yeah.
Alec had the same. He had very much the same when he was little. He was at Children's Hospital like 4 times in his first 3 years.
Yeah, he's already had pneumonia.
And are you guys aware there's an RSV shot? It's gold plated. I think it costs about $1.2 million, something like that.
The rotavirus?
RSV virus. There's a shot for that. We had to beg insurance, and then Medicaid ended up paying for it. But he got it 3 out of the 5 years, and it helped tremendously to keep him out of the hospital. Like, we were yellow gown in and out, sick. But he's grown out of it too.
That's good.
So, knock on wood to a certain extent, replaced by significant GI issues. Yay. But, still. Right.
Dear, yeah.
There you go.
Before we have about 10 minutes left in the scheduled part of the session, and I'm happy to stay after and talk to anybody. But I really wanted to address some of the cardiac issues because I know not everyone here, everyone's at a different stage in their journey. And we've learned so much about just very recently become aware of the cardiac implications of having LMNA disease. So I thought I would do a little brief primer. And then I also wanted to let you know I prepared a little handout for you guys to take home to your cardiologists, explaining about the cardiac manifestations in LMNA disease and what to be looking for. And some of you don't even have a cardiologist, and hopefully after today you will go home and seek one out because I think that's really critical. Before I do that, does anybody else have any other topics they want to get to so I don't monopolize all the remaining time?
Dr. Heller, I was actually going to ask, while you're doing that, if you would probably already plan to touch on the link and the advantages
Yes,
of that.
yes. So, so the way the heart can be affected, several different things can go wrong in the heart when you have LMNA mutations. The first thing is that the heart pump function, the squeeze of the muscle, can become weak. And that is sort of intuitive because the rest of their muscles are weak. So we know that the heart muscle function, which is in medical terms, we refer to the ejection fraction. That's how much blood is being ejected with every heartbeat, gradually goes down over time. So that's problem number one that we're looking for. Problem number two is that there can be conduction delay, electrical slowing in the signaling between the upper and the lower chambers in the heart. You know that the heart has 2 upper chambers, 2 lower chambers, and they beat in sequence. The upper chambers are supposed to contract first, and then the lower chambers wait until they receive a certain signal from the top so that they're fully filled, and then they do their thing. But it's the upper chambers that are supposed to control the timing. Over time, there is progressive delay. The conduction, the electrical signals get slower and more sluggish, and the heart rate tends to slow down. And the timing between the upper and lowers gets progressively longer until the point where occasionally you'll drop some beats. The top chambers will beat, and the lower chambers just kind of sit there and don't do their thing. So when that starts to happen, patients can benefit from getting a pacemaker put in. So the first thing is poor squeeze. The second thing is slowing and conduction delay. And then the third thing is irritability and fast, irregular heart rhythms that can crop up when, sometimes out of the blue, and they can come from either the upper chambers or the lower chambers. When the upper chambers start to become irritable and start to have bursts of irregular rhythm, it's called atrial fibrillation. And when it happens in the lower chambers, it's called ventricular tachycardia, or ventricular fibrillation, but tachycardia is the thing that, well, both of them are bad. So atrial fibrillation is something that we're seeing in the LMNA patients starting at a relatively early age, even in the first decade of life, short bursts where the heart will be in a normal rhythm and then have a flurry of 5 or 6 or 20 beats of atrial fibrillation, then immediately goes back to normal. And your kids aren't going to feel that. It doesn't impact their circulation. It's fine. You can walk around with that, and you can live that way for a very long period of time, as long as it's very intermittent and the episodes are short-lived. If the episodes are persistent, if you go into the AFib and you're in it longer and longer for hours at a time, then it can mess up the lower chambers when the upper chambers are just kind of fibrillation means that the electrical activity is kind of discoordinated and the upper chambers are quivering instead of coordinating their contraction. So when the lower chambers are perceiving this quivering from the upper chambers, they start to become irregular and often beat faster than normal because they're getting bombarded with all these little signals and they don't know what to do with it. So if the lower chambers then start to respond to the quivering in the upper chambers, the cardiac output is not as efficient. You don't get quite as much. If the top and the bottom chambers aren't coordinated, you're not getting the maximum oomph with each beat. So that definitely has an impact. As the atrial fibrillation progresses, if you're in atrial fibrillation chronically, then the blood flow in the upper chambers becomes stagnant and it doesn't move through the system fast enough, and you can develop blood clots in the upper chambers, in the little nooks and crannies in the upper chambers. And those blood clots then, if they were to break free, can travel and cause a stroke, which is pretty devastating. So anybody who's in chronic AFib or who's in and out of AFib over long periods of the day should probably be on a blood thinner, on an anticoagulant. And that's a whole process in and of itself. And we've seen that in some of the LMNA patients as they get older, in their teenage years and whatnot, often need to be on a blood thinner for that. Atrial fibrillation can sometimes be managed with medication. It also gets worse if you're underventilating at nighttime. So we know that in the adult world, sleep apnea causes AFib. In LMNA patients, if you're hypoventilating at night and not using your BiPAP effectively or not on BiPAP when you need to be, the AFib tends to be more problematic. So aggressive pulmonary care really helps keep the heart healthy, keep the heart happy. So when the lower chambers start to develop their irritability, again, isolated irregular beats from the lower chambers here and there are harmless. We all have them from time to time. They happen more often if you drink too much caffeine and if you're sleep deprived and whatnot. But if you have runs of irregular rhythm from the lower chamber, it can lead to dizzy spells and fainting. And we know that in some proportion, some small proportion of patients who have LMNA mutations, they die suddenly, unexpectedly, without warning, without any prior indication that there was something wrong with the heart. So that is sort of the scary piece of this, and why I'm a firm believer in being proactive with looking for rhythm problems early and often. How young have you heard of that? Well, in your original series, there was a 3-year-old.
A 3-year-old? So I typically send my patient to the cardiologist as soon as I realize it's MA or LMNA, or as soon as the gene testing comes back. Sometimes I'm so suspicious that it's LMNA that I might actually send my patient to the cardiologist just in case, and even before the gene testing is back, because I don't want to miss a heart problem that is completely treatable.
So the difficulty is, how do you prevent that from happening? And if it can happen in patients, I was aware of a patient that I took care of briefly who had a normal echo and a normal Holter monitor, the 24-hour rhythm monitor, and she died in her sleep one night. And I hesitate to bring that up in this. I don't mean to put a wet blanket on this, because we're coming so far and we're learning so much. But as you said, knowledge is power. So I think that message needs to get out to your cardiologist. I want to tell you, your cardiologists have probably never seen LMNA disease, and they don't know what to look for. And so this is why I prepared this handout for you to take home and hand to them, to say, this is what the disease is, and this is what you need to be aware of, because they're not going to know. Just like I didn't know. The first patient I took care of, this hit me over and over again. We would find one cardiac problem, we would treat it, think we were in a better place, and then 3 months later he would come in with a new heart problem, and I would be like, oh, now we have to react to that. And it kept going like that for several years. And so now I feel like I'm armed with this knowledge. I need to disseminate this.
Could you tell us drugs, hard drugs that are not good for laming, that would be important, because I have seen patients that have been prescribed digital, for example, and it is very frequent. So I think whenever you have a doctor that prescribes something for the heart, maybe now you know who can help us, who can help you to verify that it is, because they are good cardiologists, but they have not experience on laming. So my advice would be that you have any cardiologist who is a good one, but then whenever there's an intervention, that would be good to have somebody who that's what we do. We have a very good cardiologist for adults, knowing very well laming, but not that good for the pediatric patients. So they treat as they. But whenever there's an intervention, I ask to this very specialized LMNA patient. So that would be an advice.
Yeah. So I think digoxin is the form of it that we use commonly here, and that is a drug that is often used to control fast heart rhythms, but it also slows the conduction and can promote that heart block, which can lead to fainting episodes. So that's one to be avoided. And there are a lot of antiarrhythmic medications that are actually, they suppress some rhythm problems, but they promote other rhythm problems, so they should generally be avoided. The rhythm medication that works best is the class called beta blockers. Mm-hmm. Those are calming drugs. They slow the irritability down. They calm everything. They do slow the heart rate and they lower the blood pressure, so you have to be careful about not overdosing them and titrating them appropriately.
Sometimes they don't tolerate very well, so
right.
Your doctor should do a very
small and slow increments. Another drug that is extremely beneficial, we believe, is a class of medication called ACE inhibitors. That's angiotensin converting enzyme inhibitors. You don't have to remember this because it's all in my handout. No, yeah. That is standard, what we call heart failure management. I want to also make a comment about the term heart failure because it's a scary sounding word, but in the medical term, what we mean when we say heart failure, we're just referring to somebody whose pump doesn't work very well. And lots of people walk around in chronic, well-managed heart failure and they don't have any symptoms from it, so it doesn't mean that you're dying. So when you hear your cardiologist use the term heart failure, don't panic. It's a bad phrase, but it's in common use. So, but the standard heart failure treatment for patients that have weak heart muscles is to use beta blockers and to use these ACE inhibitors, which also lower the blood pressure. And when you lower the blood pressure, it makes it easier for the heart to pump the blood where it needs to go. And then as things progress, when the pressure builds up and the fluid builds up and patients start to get little swelling in their extremities, then we use diuretics pretty effectively. Diuretics are medicines that draw fluid out of the body and turn it into pee. So diuretics, ACE inhibitors. Steroids, that's kind of an interesting one because we don't know. In the Duchenne population, we know that steroids are very beneficial for delaying the onset of the heart disease and preserving cardiac function longer.
Reducing scarring.
Yeah.
Reducing scarring. For Duchenne.
We don't know. We have no data in the LMNA patients, and I'm not sure, I don't know if you know biopsy-wise if there's more inflammation that would be targeted by prednisone.
No, but it is something that is likely to happen because it's anti-inflammatory. So if there are some of the physiopathological the abnormalities in the heart have a point of connection that would be interesting, but we will know in a few years because many of the patients in their teens have already problems, so more or less symptomatic. So probably this will not be able to be known just now, but in a few years it will be because patients are now very well monitored.
Yeah, and I don't know if you all know that this disease, the congenital form of LMNA, congenital muscular dystrophy, was really first identified in 2008 by Dr. Quijano-Roy, who wrote the first description, she was the one who was astute enough to say there's a pattern here and recognize that they all had the same mutation, and she described the disease. So you have this person to thank for
being a smart cookie.
yes.
Thank you.
So, but that means we only have 10 years worth of knowledge.
Yeah.
The patients that had this disease 30 years ago, we didn't know that this was their diagnosis. So, so we are learning, and each passing year, we see what happens with the original cohort, and we're trying to learn from this.
I have 2 points to make. Another drug to kind of be careful about, not avoid, is that some of my LMNA kids need Ritalin or a drug similar to that for their ADHD. And Ritalin is a stimulant. It calms down the brain, but it actually can be a stimulant for the heart. So when a person already has a problem with the rhythm of the heart, you have to be careful about giving a stimulant like Ritalin, just like Dr. Heller said that caffeine is a stimulant and it can make your heart do funky beats. Most of the time, it's actually safe to give. I typically just write a little email to my cardiologist asking him, is it okay to give Ritalin to this patient? They have this issue. My patient is, seen by my heart doctor. And most of the time is okay. But that's just something to be aware of. The second thing is that especially in my older teenage LMNA patients, when they need a pacer, by the time they need a pacer, the current standard of care is to put a pacer defibrillator. Don't be afraid of that. I just want to let you know that it won't be a simple pacer. It will be something called a defibrillator. And I'll let Dr. Heller describe that a little bit more. Yeah, like the shocking thing, it has an internal shocking thing. And this is because we figured out that the Emery-Dreifuss, which is the older adult form of it, many of those patients died suddenly, and we extrapolated based on their condition that it was probably a bad heart rhythm. And we can simply avoid that by the pacer actually detecting that abnormal rhythm and shocking the patient right then and there, way before the paramedics get to the patient. So I'll let Dr. Heller describe that a little bit more. So
The average onset of pacemakers for kids.
So my youngest LMNA patient who's needed a pacer was actually 8. So young. Yeah, so it can be young. That is why we send the patient to the heart doctor. But don't be afraid if the heart doctor says, okay, it's time for a pacer, and then they might actually talk to you about a defibrillator. Don't be afraid of that. That's actually a good thing. That, if anything, can not only just pace the child's heart, but when
It's a safety net in case something bad happens.
It's like an internal paramedic. Think of it that way.
So I want to address your Ritalin question, which is very important. If you called me and said, is it okay if I put this patient on Ritalin, I would say, okay, their rhythm so far has been fine. Go ahead and try the Ritalin, but then let's get a Holter monitor after the Ritalin is started, because we want to make sure it's not triggering something. Yeah. Now, I think what Harris was just pointing out, we have an additional newer technology to monitor rhythms. The Holter monitor is you put a few stickers on your chest. Many of you your children have had them, and it's attached to a recording device which collects data for a full 24 hours while you're awake and while you're asleep, and looks for any hidden rhythm problems that your child may experience. We also have longer rhythm devices, because sometimes you can miss something in 24 hours. Suppose they're having it once a week, you may miss it. So then we have a 30-day monitor in my clinic that we use commonly. Same thing, you put some stickers on and you hook it up every morning or throughout the day. You can download the data from that actually over the telephone. It's kind of cool. But now there is a new technology called an implantable loop recorder, and the one that we're using is made by Medtronic, and it's called the Link, L-I-N-Q. It is a small single-lead EKG recording device that looks like a little memory stick that you might put in your computer. In fact, the newer ones are skinnier than that. They're about half the width of a memory stick, and they're just inserted under the skin, right over the left side of the chest, and it's done as a simple outpatient procedure with no, it's a minor procedure, and it continuously monitors the child's heart rhythm for up to 3 years until the battery runs out, and then you can actually replace it if you want to continue to do it. You take that one out and put in a new one. And the way it works is there's a transmitting device, a little box that you keep in the child's bedroom that sits on the nightstand, and works over a cellular network, and it wirelessly interrogates the little recording device. Whenever the child is within about 6 feet of the device, it will pick up the signals, and we program it to transmit usually once every 24 hours, typically at nighttime, say at 2 in the morning. We ask the device to do a scan, and if the child is within range, it will scan and pick up all of the rhythms all of the abnormal rhythms that it has recorded since the last time the device was scanned. So even if you go away for a week and then come back, you won't miss anything. We can program it. We can set the parameters and say we want to pick up every heart rhythm over 170 beats a minute, or over 150 beats a minute, or under 40 beats a minute, so we know if they're going too slow at nighttime. So these devices are very helpful, and at the moment there is a clinical trial that's going on in Barcelona where they're putting in these devices and collecting data and trying to see what we learn from this. Not everyone has the option of traveling to Barcelona to be part of the trial, so there are some programs around the country that are currently using this. I have a rhythm specialist in my department that puts these in frequently, and that's where these guys came, and we put one in Charlie, and I think it's extremely helpful, and I feel like it's the best way to be proactive and to catch things before a problem can occur.
That's what I was going to ask you. Like, what was the deciding factors, like for Charlie or whatever, like to get it? Like, should we be looking into it? Liam doesn't have any. Like, he's not
right.
signs.
Well, so there's no criteria yet for who needs one and who doesn't need one, but because the Diggs were interested in being part of the trial and couldn't manage to get to Barcelona, they said, "Hey, can we just get one?" And I thought, knowing what I know about the disease, I would love to have everybody have one from the beginning.
I can say we went to Barcelona.
You went to Barcelona.
Madison has the link, and from everything our cardiologist has told us on our regular visits, everything was fine, but we have had reports from Barcelona that she is quite arrhythmic on certain, they're not doing anything medically yet, but they are collecting data that we would not have had or would not have known otherwise. However, a trip to Spain, the sangria is awesome, but a trip to Spain is
And they can't share everything, right? With you as much
and
as
it's also written in Spanish, the reports. So the first time we got it, we got a report. She's quite arrhythmic. I flipped out. I thought that was a horrible thing, and I'm getting this report. Something's wrong. We send the PDF over, and they were like, they can read the graphs, but it's written in Spanish. So there was some disconnect, but then it was okay.
So we weren't able to make the trip to Spain because Levi can't do airplane rides. But when we talked to our cardiologist, he said that there weren't indications yet to do it. What information can I give him? Can I give him your telephone number? Can I, I think if he knew this stuff, he's very proactive and he's very good. We're very happy with the care that we're getting from him. But I would love to have the link in Levi.
Okay, one of the things that you have to be aware when you want to put this device is that it is not treating, it's just only seeing, okay? So if something is useful, it's because you will be able to catch things that are not known. For example, one of the children I saw, this one who was 4 years old, he started to have the device, and 1 month later, there was a systolia, which means that there's no.
His heart briefly paused.
Yeah,
no rhythm for 7 seconds.
7 seconds.
Yeah.
7 seconds, and the parents had not been aware that this was happening. They saw that there was happening something, but they thought that he was playing the boy with other children, so like doing theater or something. And then he recovered. So and then they could put a pacer. They didn't put a pacer because it was a small. The size was not possible to do. So this is one thing that you have to know. It may be useful, but at the same time, you only if there's something very severe that happens, maybe you just will know what happened, but that's all. And the other thing is that you have to have a very reactive and committed cardiology, because you are using something to have something, but then if it is every time happening something, you have to be reactive there. So if you have the device, but there's not a team that is really has the time, availability, and coming back for you, it is not that useful. So I think it's very time-consuming, probably for a cardiologist or for a team. So you have to be sure that the team has this interest in this disorder. I mean, it's really important. Probably not having many in the country, but having somebody that is regularly taking care of, maybe directing others. But you have to have this focused approach. And then concerning Spain people, I think they are very proactive. So they have been trying to do this in 2 years. Probably they will have to give us the analysis, and then this will be very useful. But I don't think you can do this all the time, unless you develop algorithms and that something that more automatically happening. I think it is the future, but has to be somebody. Yeah, somebody has to.
So Mark, when he had his heart issue, when we brought Madison to Spain to have the link monitor, when they heard that he also had the LMNA mutation, all of a sudden they both went in to get link monitors. I didn't know that was happening. And then when he had some other issues at a completely different hospital outside of Boston, they came with a machine and zapped at his link monitor and printed all the history of what had happened in there. So the other hospitals were able to get immediate information from that, which was somewhat.
It's all monitoring, not
And I don't want to scare anybody, but Charlie was having regular halters, and they were coming back good. And then we got the link in, and nothing catastrophic, but Dr. Heller would call and say, well, I'm seeing a little bit more. We might want to be proactive. So again, the halter was kind of one piece of the puzzle, and the link gave us a lot more. I mean, it seems like a really, yeah.
Well, what are you doing differently now because of the...
Well, he's on a beta blocker recently because Dr. Heller saw something a little bit more an increase, said, let's be proactive, let's go after this. And
Checked the BNP level, and we, yeah.
and the inclusion or addition of that medication has settled that rhythmic down quite a bit. So, and just one final thing, as Dr. Heller pointed out, it is a very minor procedure. I think it was like, it's not full anesthesia, it's the sleeping sedation.
It's like literally a tiny little incision, and then they slip it in, and they, if they sew it up, they just close it up.
It's like having a giant splinter.
Yeah.
And you can feel it under the skin, but it doesn't hurt. Can I ask you a silly question? Can it be interfered with in any way by anything else?
Like Skynet?
No, it's not intervening. It's just monitoring, right?
Yeah.
So
picking at it or like?
No, just
No, so
like when you go through.
for pacemakers, right? There probably are some, if you read the manual, they probably say don't hold your cell phone right over it, and because there's some electromagnetic interference, but no harm will come. It just means it will inhibit the ability of the device to record for the 20 seconds that it's in the magnetic field or whatever. So.
And they do say it's safe for MRIs.
Yeah.
Other,
Because it's only gathering. Yeah. It's not pushing any electric signal back to the heart at all.
Yeah,
It's just
yeah.
gathering.
Thank you.
And that's good.
And do another advice? Yes. Well, Soledad is the second maybe person in the world that has more experience in labor. So you have to.
No, just talking about this because I think it's very important, the investigation that is coming on about but I think that you can't disagree or just that being proactive with drugs, you have a lot of ways to do it without putting these things, so as not to be so anxious about putting the device. Yeah. But because with the other ways to take care about the heart, you can't put patients on medications. So I think we have. It is important to have an experience about that, but not to be very anxious about this. Yeah. No, it's like I think we have to move on, knowing more about the heart.
We have to gather information.
Yes, so as
Like if you think that having the monitor creates anxiety in the family?
I think that now they all want to have the monitor. and I think you have to take care of the heart very closely, but this is something that you have to have in mind, but you don't have to be anxious about this because you have to take care of the heart, and you can be proactive with medicine, with the way we have up to now to know how the heart is. What do you think about that?
Yeah, thank you for that. I think that's a very important point. It's certainly not standard of care to put these monitors in. It's a research tool currently, and as you said many times, knowledge is power. And so I think by we're learning things, but we don't know necessarily what to do with that information. And I'm not sure that it's going to change therapy. And if we do change therapy, I don't have any certainty that will change outcome. So there's a lot of steps in this process, but I think, I personally want to be on the forefront of finding out, and rather than waiting until something shows up on a Holter monitor and say, gee, I wonder how long this has been going on, why don't we now start treating it? I would rather sort of jump in based on my experience taking care of a previous patient who my care was completely reactive, and I realize in hindsight that we can do that better, I think. So, yes, thank you for that. My hope is not to make you extremely anxious, but to empower you.
Yeah.
You can do it in Spain too. So that's part of the it's a research study. So
And that,
they
yes.
are collecting this data to use.
I would encourage that for sure.
Yeah. Yeah, in fact, I think you have to have this approach. Is not helping maybe to your child, but it will help to the community. So one each 10 will be useful for the child, maybe. As the child I told you. But usually it will be very useful at a given moment, but to make a lot of effort and analyze and to have some conclusions. So this is the idea. So if you have the possibility to put it, and you have a good cardiologist that follows for a long time, that knows your child for a long time, and it is close, and you can, this is the ideal part. But otherwise, as she said, there are now devices that can be used, halters that are portable, that can be studying for 1 week or more, or 1 month. And so this can be used also, and you can have this other possibility to go through the problem. And the main important thing is to have a close cardiologist or somebody who knows your child, and he has the feeling of he changed something. Okay, so
I think as we're also finding out, the most valuable tool we have is each other.
Yes.
You know, and now we've got a lot of good people that we can reference and talk to.
Yeah.
Actual faces too,
I was just
like,
gonna
rather
say,
than
can we all
just a
take
random name.
Can we all take a picture together?
I'd love
Yeah. So we all can.
Yeah, sure.
LMNA family and. Right.
okay, and so then the last thing is that maybe I can share with you a little bit of points that you have been talking about and my experience. First, it was very interesting to see that it was GI, the first problem that was shown up. And I think this is also because you have children, young children. Okay, we would be in a layman AC meeting with people with teenagers, more 14. You would be talking about orthopedics or respiratory problems rather than the GI will be also. But this I think it is very important to see that it is from 4 or 3 to 9-year-old children in this meeting. So for us, we have had some problems with GI management and GI with ventilation and the tubes and everything. It's very difficult sometimes. So I would advise you to give short meals very repeatedly whenever you do not have the possibility to feed normally the children, because you can give the calories and the energy and everything repeatedly, frequently, and it will be helping to go through a bad period. I have a teenager, even 18 years old now, and he has started to be very thin, as you can have in other children, and they wanted to feed them rapidly, so they put a GI tube, and he came. We saw that the insufficiency, the respiratory insufficiency was important, so we started to try to ventilate, but to nourish at night and ventilation was very difficult, and the faces in these patients are a little bit similar. I imagine that you have seen that your children resemble, and they have a front and a nose, which is a little bit difficult, and sometimes it's not that easy to ventilate. So this problem was for a while very difficult, and the child was very, very malnourished and not ventilated. It was really, I was very, very afraid of this child. And then the dietitians had a very simple idea, was to give 60 milliliters of enteral nutrition during the day, and then he started to improve. And he still does this, even if now at his 18 years old, he eats also in the day whatever he wants, but he is continuing giving shots during the day, and this was very, very, very interesting. And I think the capacity of bowel and of stomach is not the normal in these children. I would say that probably is fibrotic, is small, so you cannot imagine that he's going to have a big meal. We know by the mice that they may have hypoglycemia. So it is important that you don't forget that he may have not more than 3 hours without having something, that it is good to give low sugars, you know. I was it's maybe anecdotic, but I have been in Italian meetings, in Europe, and I was a little bit surprised of they had a course that I would say may be better than our patients. And I finished one of my presentations like saying, well, what about pasta? But I know that my patients want to eat pasta or low sugars at night, and it is a very good idea to advise this. I advise always this.
Carbs at night, that's what you're saying.
Okay. So this is one thing. Okay. So that was about GI.
No one's ever heard of human growth hormone, right? Shots?
No, I have not heard of it. And then another thing that I wanted to share is the moment of the announcement of diagnosis. Now that the gene is well known, it's different, but we had many patients that were not diagnosed for years. And then at a given moment, we saw them, we suspected, and we do this diagnosis. So many children start to be in a myopathy circuit, and they have a lot of tests, genetic, so they know that there's something in the family, and they think they share this problem. And one of the children I was the first one I diagnosed. I was so happy to say that we found the diagnosis, and then also that it was a de novo mutation, so the parents were always scared of having another baby similar like that. And the moment I announced this, the child was there. And this child came every day to our hospital, to the school, because there was a school program there. And so the days after, he was so deeply depressed, because he was the only one to have the mutation. So then I learned that I don't want to, I want the parents to understand what it means, but I will try to be very careful to isolate the child in this troubled moment. So everybody was happy in the family except for this. So that's something. That was something I wanted to share. And then about the organization of the clinical. I agree completely with what was said. I think it is very important to have a coordinator. Then locally, it may be the neuropediatrician. In our cases, usually it's neuropediatrician, but it depends on at points of the life. It may be the rehabilitation doctor. It may be the pulmonologist or the cardiologist. And the main important thing is that you find a team, and you try to well, be finding this, and then, well, that's about. Then I am happy to answer things, but I think it's finished.
Who has the list and who's going to start the?
We have a list. We'll start up.
Cool. Are you going to do an email chain or a
Yeah,
Google
email.
group or?
Can you put my contact information for the group on there?
Yeah.
You know how to reach me.
Bye to all.
That would be
Bye.
great.
Thank you so much.
Thank you.
Thank you, Shweta.
Oh yeah.